Thank you very much. It's a pleasure to introduce this very nice meeting to discuss with the colleague about clinical application of botulinum toxin treatment to treat focal spasticity. Please, it's possible to have the first slide. Then, when we try to inject botulinum toxin in a muscle using a lot of different techniques, please, the next one. Next slide, please. It's like if we have an hole to see something that before it's impossible to see inside the muscle and inside the body of the patient. The next slide, please. Means that due to botulinum toxin injection, we are able to change locally inside the muscle the situation and to change the information that our brain is able to manage to have different movement representation, different proprioception, different pain control, and exteroception too. The next one, please. And in the same time, we change the morphological properties of the muscle in terms of elastic properties, because due to the action locally of the toxin, it's possible to stretch the muscle and to have epigenetic change of the elastic properties of the muscle. Then botulinum toxin treatment opens a therapeutic window through the hole that the needle produces inside the muscle. Today, we will have some demonstration how to manage complex situation, and Clemens will show us two different patients, and we will discuss about how the colleague manage the situation, how define the goal, discuss the goal, and discuss about rehabilitation, adjunctive treatment after botulinum toxin injection. Please, Clemens, start your presentation. Thank you very much.
My duty is to present few cases out of many we treat here in Rehabilitation Institute. And the first case is 25 years old male PhD student who suffered from spontaneous intracranial hemorrhage in left hemisphere when he was only 6 years old. The details about the event is actually unknown because he moved from other country, from Bosnia and Herzegovina to Slovenia with his parents when he already suffered stroke. So through the childhood and adolescenthood, he was actually receiving continuous rehabilitation program here at our Institute for Rehabilitation. But then he quit rehabilitation, and we met him again a couple of months ago when he came back and complained of severe spasticity. During his young time, he became a very active and successful wheelchair dancer on competitive level. And he lives in a flat adapted for wheelchair users with assistance of personal caregivers and assistants. I must say here in Slovenia, we have a very well-designed situation for a young bodily disabled patients and persons. So they are able to live with the carers or assistants which are paid by the state or national insurance. And he's a regular wheelchair user, electric wheelchair user. So clinically, I would describe these patients, a person with the left-sided spastic paresis, which is milder on the upper limb, and the severe right-sided spastic PGA. So this is the person with bilateral disabling spasticity affecting upper and lower limbs, with preserved functional activity in left upper limb and preserved activity in left lower limb. He has no functional activity in the right upper and lower limb with a high modified Ashworth score and high clonus. And his functional problems are trunk stability, reaching, grasping, coordination, and strength regulation. His functional, if we describe his functional status using the functional independence measure, we can see that he can do the feeding alone or eating alone with the prepared food. He needs assistance in grooming, especially he can actually wash his face and hands, but he has problem in toothbrushing, and this was one of his main goals to achieve the toothbrushing alone. He's completely dependent in bathing, dressing upper and lower body toileting, but he can swallow slowly without any problem. So before we started with treatment, we did some tests in occupational therapy. Our occupational therapists prefer the action research arm test, so-called ARAT, more than Wolf test, for example. And with this test, we can assess the grasping, gripping, pinching, and gross movement of the affected hand. And on the right side of the screen, on the video, you can see his problem with the right hand. Actually, he was able only to show a little bit of grasping, gripping, and pinching with a huge problem. He was not able actually to lift any object below the level of the table. And with the box and blocks test we did, actually, he was not able to move any block from one side of the box to the other side of the box. And since he's very competitive, he was quite frustrating for him. I mean, we found this actually frustrating for him. And for the assessment of the perceived problems of the spasticity, I prefer to use the so-called spasticity screening tool. It's actually a screening tool prepared by Dr. Richard Zorowitz from Chicago Rehabilitation Institute. It was published in 2017, and I actually recommend to check it. And his perceived problems with spasticity actually, and it is actually, the screening tool is actually divided in a general questions regarding the upper limb and questions regarding the lower limb. So the general questions about his stiffness and tightness of muscle, he assessed that he is extremely stiff and tight. And he was actually unable to straighten, bend, or flex the affected limbs of the right side of the body. And those spasms he described as very bad. And he had some pain. I mean, he's not suffering from the pain, but pain is still bothersome. And his sleep is disrupted because of the stiffness, actually, especially in the right arm. Actually, the stiffness of right arm is painful, and he's actually waking him up from sleep. And generally, he described muscle stiffness as very bothersome. So generally, he gets like 19 points out of 24 in this chapter, where 24 is the worst and 0 is the best. For the upper limb, he described that his fist is clenched all the time. It was a huge problem for him. And it was very difficult for his caregivers to clean the palm of the hand, cleaning the fingers. And it was very difficult to clean the armpit. Actually, the axillary region on the right side was very painful and problematic. And it was extremely difficult to put his clothes on the right side of the body. So that there was actually, from his perceived perception of the spasticity problem, actually he is very right shift, so he assessed his spasticity as a very problematic for himself. So we were discussing the goals with this patient, and we used the Canadian Occupational Performance Measure, which is very beloved by our occupational therapists, when you actually choose only one activity. And he actually chose the tube brushing with right hand. So tube brushing with right hand consists of gripping and squeezing of the toothpaste tube, bimanual, actually, including the right affected hand, tap opening, tube brushing, hand washing, and drying. And actually, this was his goal. So we were treating with injection of botulinum toxin first in the right upper limb, and typically we were treating the pattern number 4 of the Hefner classification, which is quite often pattern, very typical one. So we actually decided to inject under the ultrasound guidance, as Professor Molteni mentioned before. Actually, this is our window to the muscles. So we decided to treat the proximal and distal muscles of the right upper limb with injecting the pectoralis major muscle, teres minor, subscapularis, biceps brachii, and triceps brachii, as well pronator teres, flexor carpi ulnaris, opponens pollicis muscle, and lumbrical muscles. So another treatment, then we include him in robotic treatment for upper limb, and here we use the Hermel spring. And I can tell you that before the treatment with the botulinum toxin, even the positioning him in the handrail of the Hermel spring was very problematic, especially because of the clenching of the fist. It was very difficult to put his fist and arm on the handrail of the Hermel spring. With training, I mean, he had 10 sessions of Hermel spring training with the different games. Actually, you can see the huge difference in assessment of the active range of motion. Of course, with the support, you can see that there is 60% of support. He was not able to do it more, but the shoulder flexion and extension improved significantly, especially horizontal shoulder and abduction actually would also improve significantly, which really helped him to perform training on the male spring much better. Inner and outer rotation of the shoulder improved much better, which was probably the result of the injection of the rotator of the shoulder. Flexion, elbow flexion extension didn't improve much, a little bit as well. And the pronation and supination improved very much, which actually helped him later to perform daily activities and was the result of the injection of the pronator teres muscle. And as well, wrist flexion and extension actually moved to the neutral position much better against the from 20 to 30, then it moved from 20 to 10 degrees, which was actually helping him to use the grasp while training on the male spring. So we can actually see from this measurement on the male spring that range of motion improved significantly after the injection and after the training. So of course, after the treatment, we did the post-treatment session with the test. So on the action research arm test, or ARA, he improved from 9 points to 12. And you can say this is not much improvement, but you can see the pinching and gripping and grasping actually improved from the point of actually 0 to the point when he can actually finally take the object in the right hand and move it from the level of the table, from the surface of the table. He was able to bring, which is actually first time in his life to use right hand functionally. And also in the box and block snacks, actually he was first time in his life actually functionally pinch something and move it from one surface to the other. He moved 4 blocks in 1 minute, which is actually impossible for him before the treatment. So we actually, even this was a small improvement. It looks like a small success. For him, this was a huge success. And this was all actually reflected in his functional independence, actually. So the grooming in FIM scale improved for 1 point, which means because he was able completely to brush his teeth independently. He got from grade 4 to grade 5. Of course, in batting, he was still completely dependent. But dressing upper and lower body actually improved from that point, that he helped a little bit putting the arm and also the leg into the sleeve when his assistant was actually putting the clothes on. So actually this was, and also the toileting, actually, he was much more independent, because the right hand he was finally able to use as for reaching the handrail in the toilet. So with the right hand, he was actually able to keep equilibrium while he was doing the cleaning with the better left hand. So this, for him, it was quite also the matter of dignity, where he was actually now able to be alone on the toilet, which is a huge step forward for him. And yes, if you go to spasticity screening tool, let's see, did he have any shift on the left? Yes, I mean, still his muscles were very stiff, but at least he moved from extremely stiffness to very stiff, very difficult, straighten, but still for the first time in his life, he was able to bend or flex his limb functionally. Still spasms, he described as very bad, and the pain was the same. Actually, he didn't get any less pain, but it was not very much problematic even before. And he was disrupted by stiffness and spasticity because of the stiffen, often not every night. And he described this stiffness bothersome, not extremely, but still very bothersome. But there was improvement, especially for the upper limb. His feet didn't clench all the time, but clenched quite a bit, so it was less clenched. Cleaning the palm of the hand in between fingers was somewhat difficult, because before it was very difficult or extremely difficult. And also cleaning the armpit due to stiffness was somehow difficult, which was actually better than before, which is very difficult. And actually putting the hand in the sleeve of the coat was still very difficult, but also this is improvement. So, and then we arrived to the final goal in this patient, actually. So the goal which was chosen to reach was cleaning his teeth alone. And here we can see he actually took the toothpaste tube. He can grip it and squeeze it on. I mean, this is, for him, this is a huge step forward. He squeezed the toothpaste alone with the toothbrush and used the toothbrush both-handed. I mean, so he became independent in this activity. So actually, we were very happy with what And at the end of this presentation, I have actually my questions for Professor Molteni, which is like, we saw quite a lot of intervention. We see botulinum toxin injection, which is quite, let's say, costly treatment. We see 10 hours of treatment on Armeo Spring, which is also costly for insurance. For this, let's say, in the brackets, minimal benefit. But at the end, what is the minimal benefit for the patient, which is actually a very active? You can see him dancing here on the competition somewhere, and you can see the other competitors can hold the dancer with both hands. He's actually restricted, and he can only use one hand in dancing. I don't really know the rules here. Does he lose any points or not if he's not holding his co-dancer? But definitely, we are trying to make him better also in this field. And also, my question is, I mean, as I've explained before, she has a total assistant. He has total assistant available. There's always one person with him who can actually offer him full assistance in any activities. Shall we seek for minimal improvement in function when total assistance is available? But of course, I think yes, because we come to the question of ethics and dignity for the patient. And what would be the further treatment for this patient? Yes, I must say during this treatment, we also test the intrathecal baclofen effect with the bolus test. And actually, there was a huge improvement in general spasticity after the test. So he is scheduled for the surgery as well for the intrathecal pump implantation. So for this, I mean, this will bring the further improvement for his quality of life. And this would be actually everything from my side from the first patient case. And I'm very happy to discuss with Professor Molteni and everybody else about these patients.
Thank you. Thank you very much, Clemens. Very nice presentation. It's an excellent case to be able to demonstrate that in clinical practice, we have to combine our point of view with the point of view of the patient. Because when we talk about minimal change, it's possible to talk about marginal gain. Marginal gain in sport medicine means that you are able to change your level from medium level to top level. In a situation like this one, first of all, you treat the right upper limb, then the dominant hand, and then you restore the possibility to perform some activities during daily life, totally independent. Even if it's possible to have an assistant, means dignity. Then marginal gain, dignity are more important than a lot of scale that we are using typically to publish a paper. Then we would like to change the life of our patient, first of all. And perception of the patient of stiffness is another key point, because stiffness don't mean pain, but is an unpleasant sensation. Then, during your using your ability to analyze deeply the patient, you are able to define marginal gain, very important for the patient, to increase dignity of the patient, and to reduce unpleasant sensation. Very, very important goal for daily life. Finally, about ITB treatment. I totally agree that it's possible to use this one, but we know perfectly that using ITB, it's impossible to be able to change something locally on the upper limb. Then means that not only we have to perform a global evaluation of the patient, and we have to learn from the patient the goals that we have to reach all together, but in the same time, we have to think that it's possible to combine different treatments. Local, very precise, using ultrasound localization of the muscle after global clinical evaluation of the patient, and global treatment using ITB. Is an excellent case, this one. And finally, last comment. You treat a patient a lot of years ago after the start the problem, and you are able to change the life the quality of life of the patient, even if you have a problem a lot of years before. Then no problem to treat chronic condition, no problem to define marginal gain, very important goals together, discussing with the patient, and finally, combine other treatment tools. Excellent, excellent presentation. Thank you.
Thank
Do
you,
you have any
Professor.
other comment, Clemens?
Yeah, of course. I have a lot of questions for you. I mean, I'm happy to have you here. Well, as I mentioned, when we tested his intrathecal baclofen effect, we did it with the boluses, but we also have an option to test the intrathecal baclofen effect with external continuous delivery through the external pump. In that case, as you saw these patients, would you be satisfied with just a bolus test, or you would rather put the continuous infusion 24-hour with external pump?
In our center, we try to discuss with the patient about the goal before any test of baclofen bolus. And we prefer to have just a bolus, not to have an external device to follow the patient for some weeks. In some other center, they use it, but in our experience, maybe better to define exactly the goal with the patient, because we know that particularly in complex situations like this one, the bolus means we are able to change globally something. And the fine-tuning of the dosages is something that we have to perform in some months, not just in some weeks. Then yes or not is not just depending on the bolus, but in the previous discussion of with the patient about the main goal that we would like to reach, even if you have to implant an intrathecal baclofen pump.
Well,
is another option to have an external temporary device, is another option. What is your experience about this?
Well, we have both options. We test the patients with the periodic boluses every 24 hours, or we use the external. It's Italian product. It's Chrono 5 pump, and it's a very detailed pump, and we use it mostly for let's say high functioning patients. So these are usually spastic paraplegics. Who are active all the day, or they are even professionally active. They drive a car and so on, and we just really know how they run through the day with the continuous flow of intrathecal baclofen. My problem here, when I decided how to test this person, was actually, is this person low functioning or he's a high functioning person? Because if we assess him from the clinical point of view, he's actually functionally tetraplegic, so he's a low function. But if we see his life, he has a social life, he goes out, he do his PhD degrees from the international relation in university. He's a dancer. I must say he's a world vice champion in solo dancing on a wheelchair. I mean, he's an ambassador of Paralympic sport. I mean, clinically, he's low functioning. Socially, he's top functioning patient. So I was in dilemma how to actually test this patient. But it's always a dilemma to describe what is high and what is low functioning patient. This is true.
I totally agree with you. We have a discussion during a meeting focused on ITB, how to define high functioning or low functioning. And I agree totally with your point of view. High functioning means in terms of ability of the patient to have a social life, more than to move something or some part of the body. And particularly a patient like this one is exactly the same for ITB, means marginal gains. Marginal gains may be very important. Finally, unrelated exactly to this case, sometimes you have to combine intrathecal baclofen pump and botulinum toxin for the upper limb to reduce the need to increase dosages. Because particularly in patients like this one, if you increase dosages to try to reduce spasticity on the upper limb, you have an impairment of trunk control. then the combination of treatment is to maintain the maximum benefits from ITV and the maximum benefit from local treatment.
Yeah, thank you. So can we say, Professor, that it's always worth to treat the patient, even if we see the goals as marginal or very little, because those goals are little just for us? Is it true?
You have to do a lot of work, even if you have marginal gains, because it's very difficult to decide the amount of gain to justify something without the opinion of the patient.
Exactly. Yeah.
Because it's like to say, if you have a cancer, no reason to perform any treatment if you have just 1 year of possibility to survive. Who decides this?
Exactly.
This is another situation. This has quality of life. You have a very long-term perspective for the patient. Why you don't have to change the quality of life of your patient? You have to do this. Absolutely.
Thank you.
And finally, I would like to stress that you perform post-injection treatment, adjunctive treatment, using technologies, using typical conventional treatment, but particularly in a patient like this one, is very important occupational therapy to be able to increase the marginal gain that you are able to introduce using botulinum toxin.
Thank you.
The next case.
Professor, do we get any questions from the audience?
In this moment, I don't have any question from the audience.
Okay. So I will share my screen now for the next case. Okay, so I will present now the second case of the patient, This will be maybe a less challenging and less enthusiastic case, but I would like to present you a 42 years old lady with primary progressive multiple sclerosis, which was diagnosed in 2001. And her current extended EDSS scale is 8. From other diseases, she suffers from osteoporosis, and she's on the treatment with risedronate, and she has also irritable colon, and she's treated with mebeverine. As the patient before, she lives in a flat adapted for wheelchair users with assistance of personal caregivers as the previous patient. She's a passive wheelchair user. She's not able to run the wheelchair actively, and she was really never happy with the electric wheelchair we were trying to prescribe her. So she never became a friend with electric wheelchair, so she kept as it is. And her favorable therapy and, let's say, activity is horse riding in the meaning of the hypotherapy. We have option to use the horse of the hypotherapy, and maybe this is because he's a physiotherapist by profession and she's very much educated in medicine. I would describe her clinical status as a moderate left-sided spastic paresis, milder in the upper limb, and severe right-sided spastic paresis. So again, I would describe this lady as person with bilateral disabling spasticity affecting upper and lower limbs, with some preserved functional activity in left upper limb and preserved activity in left lower limb with the Ashford score of the tone 2, and no functional activity in the right upper limb, and severe right plantarflexors and moderate right hip adductors spasticity. So this reflects on her functional status as a very much dependent person. I mean, she can't even feed herself, so she's dependent in feeding, grooming, bathing, dressing upper and lower body, and toileting, but she can swallow slowly the food she was fed by the other assistant. And this is again the spasticity screening tool for her. I will not go into the details, but again, she described, as we described before, her limbs as very stiff and tight, and it was very difficult for her to straighten, bend, and flex the arms. And spasms, which came unpredictably, were somehow bad. and she had quite a bit of pain. Actually, it was not a lot of pain, but quite a bit of pain. And very often she was waken up during the night due to the spasm and pain. And generally, she described her stiffness of the muscles as a very, very bothersome. In the upper limb, specifically upper limb, her hand was clenched somehow. I mean, not a lot, not extremely, but somehow. And cleaning the palm of the hand and between the fingers was somehow difficult, and also putting the clothes on was somehow difficult. The most problem she complained of was pulling and curling and sticking the foot, the right foot. Actually, this is very bad for her and also very painful. And it was very difficult to move her right leg due to the tightness. And extremely difficult was actually, or very difficult was actually to put the shoes on the right side. So this was the most, let's say, time-consuming activity in the morning, was putting the shoes on for her and putting off in the evening. So actually, we actually after examination, we decided to inject the botulinum toxin again in the right upper and lower limb both. And we decided to treat proximal spasticity of the right upper limb with injection of the pectoralis major, teres minor, and subscapularis. And in the lower limb, we injected proximally and distally in the gastrocnemius, medius, and lateralis, musculus soleus, biceps femoris, semitendinosus, and also semimembranosus, again under the ultrasound guidance. Okay, so when we asked her with the spasticity screening tool again, how she actually feel the problematic spasticity, actually we can see the shift to the left, I say. So mostly she described the problematic of the spasticity as light or little. There were spasms were much better and much less. And even the pain, especially in the foot, actually improved. I mean, she had a lot of pain in the foot before, and now she felt a little pain. And what is most important, actually, her hygiene improved in the palm and armpit, and which was very good actually for assistant, was that they spent much less time for putting the shoes on and off, which was a crucial activity during the day when they went out. So actually on the screening, the spasticity screening tool, actually we can see the shift on the left, which means less points and improvement in the perceived problematic of the spasticity. Of course, this lady, we actually carefully choose the goals, actually, and we try to assess with the goal assessment scale. And actually, our first goal was that upper body clothing will be done, of course, assistedly in at least 25% less of the time, which was usually 5 minutes for the upper limb, or upper part of the body. Since with the assistant, they improved this time to less than 2.5 minutes for the whole upper part, actually we graded the goal assessment scale as +1. Axillary hygiene became notably less painful for the patient, which we said, okay, at least 1 score on visual analog scale improvement, we would be happy. And she actually said, yeah, I mean, it's notable less painful, so we graded 0 on gas. Correction of trunk position in a wheelchair, usually, I mean, performed by assistant, was usually be done many times per hour, like 2, 3, 4 times per hour. She needed assistant to correct the trunk position. And after the treatment, actually, the trunk position correction was needed less than once per hour, actually, which actually lessened the presence of the caregiver with her. I mean, she got some, let's say, independency and intimacy. I mean, she was actually able to be alone in the room without being corrected. And shoes will be put on by assistant in less than 3 minutes. I mean, this is very good for the assistant, because the putting shoes on and off were done in 2 minutes, and we assess this as the mark +1 on the goal assessment scale. Also, assistance in wheelchair to bed transfer will demand less than 50 or to 75% of assistant effort, and really improved from gross, let's say, 75 to total assistance on transferring to 50 to 75. So we said, okay, we reached the goal as we wanted. And during the hippotherapy, during the horse riding, only 1 assistant will be needed for keeping the sitting position during the riding. Mostly there were 2 assistants needed, 1 on the right and 1 on the left side of her on the horse. So actually, from the organizational point of view, or staff demanding point of view, this is a very good one, because she just needs one usual caregiver to help her during the riding. And what is most, let's say, not surprisingly, actually, we can explain that, or I will ask Professor Molteni to explain it very nicely. Now, her speech improves very much when she gets her limbs injected with botulinum toxin. So our goal was that she will produce more than at least one uninterrupted sentence in oral communication. When I spoke with her on the phone, I was very much impressed, because she produced more than one sentence on the phone conversation. She can speak one sentence and another, and then she need a rest. Before, actually, she interrupted her communication inside the one sentence. So if she can say one sentence fluently, was quite well. And her perceived breathing effort was diminished. I mean, I always say, okay, do you have any problems with deep breathing? Say, yeah. I mean, so let's try to diminish it, because she, in the previous injection, she found out actually her breathing perception was actually improved. Her perceived effort of the breathing improved after a botulinum toxin injection. And now actually she assessed that the effort was diminished for 25 to 50%, which actually we came down to the question of energy preservation for the other activities, because she needs less, let's say, less energy just for breathing. And yeah, I mean, again, we found her some interesting goals here, which are maybe difficult to explain somehow. But my question here would be for discussion at Professor. I mean, I didn't really mention modified Ashworth score much. So does anybody care about Ashworth score when we speak about the severely disabled patient due to spasticity? Because we all agree that we don't treat the Ashworth score. We actually try to relieve the burden of spasticity, which is most important. And of course, the question is, in severe disabling spasticity, whom do we help? Do we help patient or helper? So this is my presentation of the second case, and I would be happy to discuss with Professor on any other on this case, especially about the last three questions and discussions. So I'm.
Thank you again, Clemens. Another excellent presentation of a different case, but with a lot of possibility to discuss how to manage our clinical practice. First of all, you ask, we have to treat Ashworth or we have to treat a patient? This is a key point. Ashworth scale is a way to define locally the spasticity of the muscle, but generally speaking, unrelated to the goal that we would like to reach. Then to define the goal is completely different to define locally the spasticity of the muscle that we would like to inject. Two different situations that we have to face. Second one, I have a question from the audience about how to be able to have a structure of feedback formal from the patient. There is the possibility to have something related to perception of change. There are a lot of scale focused on the perception of patient of change before and after treatment, and it's possible to use it to define if we are able to reach the goal or not, first of all. And second one, it's possible to involve the caregiver. That sometimes is the real goal that we would like to reach, to reduce caregiver burden of the assistance is another key point. And finally, particularly in this patient, is a neurodegenerative disease. And using your clinical approach, you are able to follow the patient year by year. When change the situation due to the neurodegenerative disease, you focus different goal in different condition of the patient in different years. This is another key point. In neurodegenerative disease, we have to be able to follow the patient. Is another very important point. And finally, another question is what to do when botulinum toxin is not enough. We discuss about physiotherapy. We discuss about intrathecal baclofen pump. It's possible to perform surgical procedure to facilitate the management of the condition of the patient. Then we have a lot of different options, but obviously it's very important to be able to integrate everything inside a global picture of the patient. Do you have any other comments, Clemens?
Yeah, of course. I mean, I would say the question, what to do when botulinum toxin is not enough? I don't want to be harsh to anybody, but my answer will be just botulinum toxin is never enough, because botulinum toxin per se alone, it's not really a treatment. It's actually a huge poison. And for me, botulinum toxin is always, just as you said before in the beginning, therapeutic window. Just in toxin doesn't really actually improve much the function, but with the botulinum toxin injection, we are able to make other therapies much more effective. And this is one of, so I would say usually when there is a spasticity, but should be different, but it's never enough. In my clinic, we have kind of a rule that when patient is not able to get additional adjunctive therapy, we don't treat patients just the way they come for botulinum toxin. If there's no further complementary or conjunctive therapy, we don't inject.
This is a very important point. In a situation like this one, may be very important education of the caregiver.
Exactly. Yeah.
Education of the caregiver may be very important to manage situation like this one. One more question for you, Clemens. What about dosages? When you look to treat spasticity in multiple sclerosis or brain injury, do you have any different clinical approach in terms of dosages in neurodegenerative disease versus traumatic brain injury or stroke?
No, actually, I don't. I mean, the total dosage is actually really depends on the distribution of the spasticity in my experience, and I actually the dosage regarding here we of course we use our doctor's perception of the spasticity. So more severe spasticity, whenever it is the origin, spinal or brain-derived spasticity, I decide on the, let's say, of spasticity. I don't really distinguish generally if it's degenerative or it's traumatic, but the total dosage usually depends on the distribution of the spasticity.
Okay.
What's your opinion about that?
If you look the problem of reinjection rates, do you use a fixed reinjection rate time, or you change depending on the condition of the patient or the season? Because maybe that during the winter time you have a different situation compared to summertime.
That's excellent idea. Well, I would say 75% of my patients, I use the fixed inter-injection period, which is 3 months. In 25% of my patients, I actually adapt to their needs, and it's working quite well. 25 patients, they need a shorter inter-injection gap, or they need a longer. But usually call them back every 3 months in the majority of the patients. In the minority of the patients, yes, we are adaptive to their needs and the expression of the spasticity. The injection adjusted to the certain time or season of the year. Well, in Slovenia, we live in a quite moderate seasons, so we don't have a very, very hot summers or very cold winters. But definitely, I mean, I would say there is a question of hygiene. I mean, in the summer when it's hot and patients are sweating more, the need for the hygiene is, of course, more intensive. And in that case, I would consider this to actually inject more often, just to patient to change the clothes more often, or to do the hygiene cleaning more often.
And again, I totally agree with you. Obviously, is an excellent possibility to be flexible in terms of timing of reinjection and dosages too. And what is your experience when you start to treat a patient for the first time? You use the maximum dosages that you like immediately, or you try to move progressively to high dosages?
Yeah, we for the second question, yes, we do progressively. We try to treat spasticity with the lesser dose needed. Okay, and when we start actually as soon spasticity become anyhow bothersome or influential on the patient status. This could be pain, this could be therapy, this could be orthotic fitting, this could be enlargement for, let's say, skin ulcers, anything. Whenever I saw the problem, spasticity is causing a problem, I start to treat it. Even if it's mild, we treat it with the lower doses. We never wait. I mean, at least in my perception, we should never wait spasticity to be fully developed before you start to treat it. I mean, I'm a, let's say, I'm a promoter of the early treatment.
And finally, another problem is focus on how to manage orthosis before and or splint for the upper limb before and after treatment. And again, when you have a patient unable to walk, like the patient of the first case that you present, the problem of the wheelchair clinic to increase the results that you are able to reach, because maybe the change in the wheelchair, some possibility to support in a different way the trunk, change the ability of the patient to control the upper limb. And finally, try to personalize the orthosis too is another very important goal.
Exactly. I'm lucky actually. I work in a nice rehabilitation institute. We have a nice department for orthotic fitting as well, orthotic and prosthetic department, and we have a very experienced occupational therapist. Well, my rule is that when I see the patient who would need orthosis, correction orthosis, or splinting, of course, I always first inject. Then we wait 7 to 10 days until the beginning of the effect of botulinum toxin, and then we go to the fitting and measurement. So orthosis is usually done on the limb which is already treated by the botulinum toxin, because we believe we achieve much better range of motion or aesthetic position of the limb after. I mean, orthotic fitting, it's a huge problem. We all know that the patients with a severe spasticity, distal spasticity of the upper limb, they are not compliant to wear orthosis because it's painful for them. So first, we reduce the spasticity, we reduce the pain, and then we fit them with the orthosis because the compliance is much, much better, especially with the children, of course. Regarding the inclination of the wheelchair or adaptation of the wheelchair, yes, I mean, this is the basic, actually. I mean, we all know how important is the positioning of the patient, especially for a patient with disabling spasticity in the upper and lower limbs and in the trunk spasticity. This is immeasurably important. Inclination of the seat, positioning, support, the size of the wheelchair matters. I mean, it's very much important. I mean, the sitting procedure and the sitting adaptation is actually the crucial for the wheelchair users, especially as the first patient I described. I mean, in wheelchair, this is his life. I mean, he's let's say 18 hours per day he's in a wheelchair. I mean, if the wheelchair is not adapted, inclined well, supported well, I mean, of course, the bad wheelchair sitting promotes spasticity very much. I mean, you can treat spastic limbs, but when the patient is not sitting correctly in the wheelchair, it will not help so much. And yes, on the other hand, with the treatment of the spasticity, we can actually make the sitting better. And so we actually cut this circulus vitiosus of the promoting the spasticity with the bad sitting or wrong positioning in the wheelchair. If we position patient well with the botulinum toxin, the wrong positioning in the wheelchair will not be promoting factor for the spasticity. And this is what you said, this is extremely, extremely important, of course.
We have two questions, and then I think that we have to finish. The first one is related to, it's possible to have, in a long-term perspective, muscle atrophy due to reinjection of botulinum toxin? The answer, from my point of view, I have experienced in the last around 30 years, no major problem of atrophy of the muscle if you perform adjunctive treatment. If you have atrophy of the muscle, means that you inject the muscle and you don't do nothing. This is a key point. Then botulinum toxin plus adjunctive treatment to reduce the possibility to have atrophy. What is your experience or opinion about this?
My experiences are not so huge as yours. From my personal point of view, I haven't actually found that I would, let's say, that even long-term injections would produce any atrophy per se in the point of injection. On the other hand, we all know that actually the spasticity itself preserves tone, the muscle tone. It's kind of spasticity, we call it its paraplegic friend. But I never, in my experience, found that that would be atrophy caused just by injection of the botulinum toxin. And I actually agree with you that if actually we bring the activity into the muscle or into the limb with improvement of the range of motion, because no range of motion, it's actually minimum activity. Improving range of motion with injection of botulinum toxin will bring us back activity and muscle control and cortical control of the muscle, which is actually preventer of the atrophy. So me personally, I haven't had a patient who would actually, we noted atrophy just from botulinum toxin injection.
I totally agree. Then last question is a very nice question. How to facilitate home training, particularly during this pandemic period? I think that we have to introduce the concept of teleconsultation and telecommunication. Then we have to learn how to use it to maintain regular follow-up with the patient and to check if all the educational program that we start inside the hospital with physiotherapists and so on are programs that the patient is able to perform at home too. Then telecommunication will be the future to increase follow-up and relationship with the patient. I hope that we will learn to use it in the right way, maintaining friendly relationship with the patient. Do you have any, we start to have experience about this. Do you have any experience related to teleconsultation and telecommunication feedback?
Well, yeah, I must say, we don't use it as much as we could, probably, I would say, but because we are lucky, because we live in a small country, so the patients, it's not a big problem for the patient in Slovenia to come for a regular follow-up, so a live follow-up in my outpatient office, where we actually check the effect of the injection, and we also check the patient's understanding what he should do, and we also always check how much therapy and where and which one he got in his, let's say, domestic, in his local community. But yes, for, let's say, severely disabled patients for which traveling is a problem. I mean, they need to get an ambulance car, which is also expensive again. And so, okay, we use the we just use the telephone call. So we call direct the patients or the caregivers or patients or relatives, and then we go through the checklist, and especially this is very useful for checking the perceived feeling of the implant, because I would say nobody know better about the spasticity of the patient but the caregivers, or those who are actually living and doing all the activities with the patients 24 hours per day. And I'm really happy when I get a feedback from mother or wife or caregiver. Yes, doctor, now it's really much easier to put the trousers on. It's really much easier to put the clothing on the upper body. And it's really much easier to put him in a wheelchair. We have patients like that. And I'm really happy when I get this information. And I know that because with that, you really relieve the burden and stress of the caregivers. Because especially in the severe injuries, like severe brain injury, we all say it's a one diagnosis with the 4 patients. I mean, it's not just a patient, it's a family that live and work with the patient. And when we relieve the burden of spasticity on the daily care, we did everything, actually. We did everything.
Thank you. I think that we have to finish. I thank you. You present 2 excellent cases, able to share experience about how to manage in real practice global disability. I think that the key message will be, first of all, patient perception is more important than actual scale. Global evaluation, to combine different treatment, to use adjunctive treatment. No problem about chronicity. You have to follow the patient for all the life of the patient. And telecommunication and teleconsultation will be another possibility that we will have in the near future to maintain strict relationship with the patient. Then we have to select the patient, to select the goal, to select the muscle, to decide the dosages, and to define all together what to do immediately after injection. I think that by this way, we will be able to change the quality of life for our patient and sometimes the ability of the patient to manage the body and the relationship with the person around the patient. Thank you very much. I hope that you enjoyed this meeting. It's a pleasure to meet you, and we will have in the near future other possibility to share other experience. Thank you very much.
Thank you very much, Professor Molteni. Goodbye.
Bye-bye.
Bye-bye. Bye-bye.